Hello everyone. Hello, welcome to this very important event we're having on the vaccine take-up by the BME. But before I actually start the formal event itself, I just want to go through some introductions and some housekeeping. Let me begin. My name is Ravi Arora. I am the Director of Multicultural Richmond, a local charity which has been operating for about 30 years. Our aim is to create an inclusive and integrative multicultural communities in the London Borough of Richmond and Hounslow, and surrounding boroughs. Our aims are actually to reduce and eliminate discrimination and support people from all backgrounds, all cultures, all races, breaking down the barriers so they can become part of the wider community and flourish in British society. Now, this event, thank you for joining us. This is a very important event, and the reason for this event is because we know this COVID-19 has had a disproportionate effect on the BME communities, and we also know that the take-up of the of the COVID-19 vaccine has been low amongst the BME communities. So this event has been put together by the NHS, South West London Clinical Commissioning Group, and Richmond Council. So thank you very much for doing that. Just a bit of housekeeping now. We are recording the event, so people who can't attend can watch it later. We will begin with a short presentation, giving an overview of the vaccination, and then there will be followed by question and answers. We aim to get through as many questions as possible as we can and give everyone a fair chance to actually ask a question. But if you do want to ask a question during the event, rather than putting the virtual hand up, we are going to ask you to put the word question in the chat. And I will come to you as soon as you put that word in the chat, so it avoids virtual hands being kept up for a long time. So please, if you've got a question, can you please put it in the chat and write question? So write the word question. So don't fill out the whole question, just put in the word question and I will come to you. And when it is come to your turn, you will be unmuted. I would just like to now to ask the panelists to introduce themselves. Patrick, can you begin?
Certainly. I'm Dr. Patrick Gibson, GP in Barnes and GP lead for Richmond Borough.
Dr. Mariam?
Hi, I'm Dr. Mariam Miran. I'm a GP in East Sheen and I'm Macmillan GP for Kingston and Richmond.
Dr. Jane?
Hi there, I'm Jane Jacob. I'm a GP based in Richmond. I'm a clinical lead for care homes, end of life, frailty and diabetes.
Thank you. And so can we now begin, Patrick, with your presentation?
Certainly. Rachel, can you put the slide up for me there, first one? First thing I'd like to say is I'm really glad to be here. Inequalities is a topic that's really, really close to my heart. There are all sorts of inequalities. I grew up in Liverpool and with Northern Irish parents, and I know what it was like for the Irish in Liverpool at that time. So I have a sense, I've grown up with a sense of what it's like to live in an unequal society. And from a health point of view, I'm not sure that we have done fantastically well over the years at trying to address those inequalities. We have an awful lot of work to do, but I do think that we are in a climate now where we can seriously start to do something about that. And certainly under my watch, we will be doing everything we can to try and address some of that. So, Rachel, do you want to go to the next slide, the second slide, please? So where are we with this? I'm not going to spend too much time on the basis of the vaccination program because it's so well established. I think most of you will know where we are. The government set up a joint committee for the vaccination and immunisation, JCVI, which you see quoted a lot in the press, and that is a committee that is answerable to the Minister for Health, and that is the agency that determines the programme for the vaccination. So it identified at the start a set of cohorts, and those cohorts were based on identifying which members of the population were at greatest risk of getting complications and dying from COVID. And they identified quite early that care home residents were very high risk. And then the biggest impact after that was mainly age rather than any other factor. So the next bit was then to hit 80, to target 80-year-olds, 75 to 80s, 70 75s, and work the way down. We also identified that patients who had conditions which caused them to be shielded needed to be prioritised highly as well. So they were in cohort 2 after cohort 1, which was the care home residents, and healthcare and staff were in cohort 1 as well. And then the other group that were identified as being at higher risk, separate from age, were carers and patients with clinical conditions that put them at greater risk as well. And that came into cohort 6, and that covered off a lot of diabetics and some patients with respiratory disease and so on, who were not so severe that they were going to be in the shielded group. So that's the way the cohort system has worked. The interesting thing about the cohort system is that although we knew from early on that ethnicity was an issue, it didn't reflect itself enough in the data to impact on the prioritization process. However, there was, from early on, because we were aware of that, there was a lot of work going on to try to identify how you incorporate that risk that goes with ethnicity into the prioritization, into the cohort arrangements. And that's why when the second group of shielded patients were announced about 4 weeks ago, that cohort was was identified by looking at a whole series of parameters that might affect an individual risk. So obesity, previous history of gestational diabetes in pregnancy, and ethnicity fed into that. So as a result of that, and this was a thing called the Q risk assessment, we were able to identify another 1.7 million who were more at risk, and that population were then identified by their practices, who were told that their patients were in that, and that meant that we were starting to use ethnicity as a means of prioritizing patients within the cohorts. So we're now at a situation where everybody over the age of 60 has been offered a jab. Some have declined, but the take-up rates have been near 90%, so much higher than we would ever have seen in any other vaccination program. Richmond's done 62,000 jabs since the 8th of December, and we have had 6 vaccination sites associated with practices, in addition to the mass vaccination sites and the roving vaccination that has been provided by our community provider, Hands Own Richmond Community Health, and also some vaccination been done in hospital settings as well, and particularly for more elderly residents who happened to be in hospital at the time when the vaccination was there. So there is data fed back to us on a Thursday, so we see how we are doing compared with our peers, and the good news is Richmond has been ahead of the game most of the way through. So next slide please, Rachel. So that talks about those cohorts that I was referencing. Cohorts 4 were picked off some time ago. Cohort 6 has got a complex mix of people, and the local vaccination sites have been told to focus their attention on cohort 6 to make sure we pick up the underlying health conditions and the carers, the homeless, asylum seekers, there are various cohorts of hard to reach people who we've been asked to include within that. And that's been the focus of our attention. Because our vaccination site's been so successful, we have contacted a lot of the patients within that and vaccinated a lot of people within that, and are actually now moving down through the age groups lower than that. So we know that many of the people in the cohorts, certainly from 7 have been already offered vaccination. So we are well on the way with that. Next slide, please, Rachel. So it's currently been offered a vaccine. So anybody over the age of 50 will have been contacted, or should have been contacted, with a letter from centrally from the NHS and invited to contact the mass vaccination sites to make an appointment for that. At the same time, individuals may well have had contacts from their local vaccination sites, their practices, to offer them a vaccine there as well. The cohort 6 is the people at high risk of coronavirus, frontline health and social care workers. They are in category 2, so cohort 2 for vaccination. So the reason we've put them on that list is that as we work our way down the cohorts, we continually check back to make sure they haven't missed people in those higher cohorts who still need to be vaccinated. The vaccination sites are making 3 offers to all patients, and of course patients are free to decline, but if they decline 3 times, that does not mean that they cannot subsequently access the vaccine. It's very important that if people have declined previously and changed their mind, the vaccine is still there for them. The door is always kept open. So moving down, patients who put in a high risk, covered that off. Learning disability was identified early on as being a risk, and we have done a lot of work and have vaccinated large proportions of patients from our learning disability group, and we are trying to make arrangements, promoting arrangements that make that easier. So bringing patients in at a quiet time in surgeries, maybe even doing it at home, using distraction techniques, using local anaesthetic. So anything that will make that process easier for them. The carer I referenced earlier on as being part of cohort 6. It's really, really important that we look after our carers. They do a huge amount and save the country a huge amount of money in care costs, and it's really important that they are vaccinated, because it makes absolutely no sense to have the person who's caring for a dependent individual out of action, causing the care of that individual to have to pass over to statutory services. So carers have been encouraged to contact the practices, make sure that they are on the practices registers as carers, and then the practices are in a position to invite them in for vaccination. So next slide, please. So AstraZeneca, there's been a lot of publicity in the last couple of weeks, most of it extremely unhelpful. We're in a unique position with this vaccine. So 27 million doses given. If we haven't identified trends within 27 million vaccines, there is something going wrong with the system. So with the vaccination system, there is a yellow card system. So if patients have had an abnormal reaction to it, or a reaction that is of concern, the doctors will be reporting those nationally. So that data is collected. And that's why I'm saying that if there's 27 million given, we should have identified much earlier if there was a major issue. And the clotting issues that I know have been a concern for people who've submitted questions in advance for this meeting. We would have been aware of that earlier, but after it was raised, of course, people do start to look back at the data just to double check. And we're in the happy situation now that the European regulators and the states regulators have all looked at their data, and there is no evidence that you are any more likely to have a problem with clotting and thrombosis than you would if you hadn't had the vaccine. So that's good news to be able to give that reassurance. And we do not want people to use that or to feel that is a reason why they should delay, because delaying having the vaccine is an infinitely greater risk to them than anything that's going to happen as a consequence of the vaccine itself. So I think that's the last slide. I I just want to give a little bit of background in terms of the issues about ethnicity. So early on in COVID, we knew there was a problem. There was some early research in May which indicated some ethnicities were at higher risk, and that was confirmed in July. So in particular, it looked like Black and South Asian ethnicity had a higher rate of death, higher risk of death than white ethnicity. So the data initially was across England and Wales, although they did break it down later to England data. So the highest risk in those early months was attributed to male Black Africans, who had 2.7 times higher risk of death, and within the female population, it was the Black Caribbean women who had 2 times a higher risk of death. Sometimes there are genetic predispositions that play into this. There are some conditions that are associated with particular ethnicity. So diabetes, cardiovascular risk with South Asians, for example, and that might have been part of the reason for that. So there was an attempt to try and sort of correct for those factors, but even when you correct for factors of relative wealth, so deprivation we know is an issue, but even when you correct for deprivation and those associated health issues, the complications, the death rates are still higher. So when they subdivided the England and Wales data to just England, so England on its own, Black African males without that correction, we're looking at a 3.8 times risk, so even greater than the England and Wales figures. And Black African women, it was 2.9 times the white population. So once they corrected for those factors, so the deprivation factor and the associated health issues, that came down to 2.5 for Black African men and 2.1, but that's still significantly above. It's more than double the rate of the white population. So this is a significant issue for our Black and Asian groups. Similar variation was seen in care homes, interesting as well. So the death rates where residents came from particular ethnicities were higher, that reflect in the same pattern really there. So the good news, I suppose, is that although there were concerns early on about take-up of vaccine in the different ethnic groups, we are narrowing those gaps. So in February, white residents were 2.1 times more likely to get vaccination than the other ethnic groups. That's now down to 1.6. And in February, the most affluent were more likely to have it by a factor of 1.6. And that's come down to 1.1. So the messages that we're getting out to the public about the safety of the vaccine and the fact that there is a need for some populations to have the vaccine even more than others, we are getting through there. So that's reassuring, really. So we know that people with a higher rate of mortality now are 2.4 times more likely to have been vaccinated than people who don't have higher risks of mortality, and patients with long-term conditions, which covers some of those issues I was talking about before, including diabetes, 2 times more likely to have been jabbed. So we are making progress with that. But I think there may be one more slide, Rachel. Is there a slide that just reflects the, yeah, lovely, thank you. So this is there are 2 sides to this. The left-hand side of the slide talks about where deprivation plays a part. So the part of this that is most relevant, if you look on that left-hand slide down towards the bottom, you've got those grey and blue charts, and then on just to the right of that, you've got a line that goes down with movements across that line, and that shows within that population. So cohort 10 is the most affluent population. Within that group, you would expect, if you had the standard population, so if everybody's having vaccines at the same rate, you would be right on that line that goes from top to bottom. So the most telling piece of that is that if you look at deprivation index 1, 2, and 3, those are the populations who are less likely to have had the vaccine. And then if we move on to the right-hand side of the slide, that talks about the same issue, but by ethnicity. So what you will see there is that there is an overrepresentation of white people having the vaccine than you would expect for the standard population. And you will see that within the Black resident population and the Asian resident population, those have been underrepresented. Since those figures relate to about a month ago, and that gap has narrowed. And actually within our Asian population, we're near now to that central line. So as I say, we are making progress with this, but there is work to do, and that's why we have dedicated our time today to this meeting. So I think I'll stop there because I know the main purpose of the meeting is to invite the questions and answers. Thank you, Avi.
Thank you, Patrick. I'm going to kick off with the first question, and that is really, I know you just talked about the vaccine, but really how safe is it really, and are there any long-term impact on taking the vaccine?
Want me to take that one just to kick off, and then we'll maybe rotate around the doctors after that. So this is a very safe vaccine. We've been unbelievably lucky with this. So if we make a comparison, for example, with effectiveness, the flu vaccine has a success rate of about 40 to 60%. So it's about that sort of range. So with these vaccines, a single vaccine gives a protection rate higher than that, and a double vaccine, so having your booster vaccine, and the success rates there are 90 and 95% with the two products that we've got in use at the moment. So that's absolute protection from the disease. If you actually take into account what we're trying to achieve with it, we're actually trying to stop people getting really serious disease. So it's the hospitalization, death, and the long-term complications. So those 90 and 95% figures underestimate what we achieve with that. So it looks like the vaccine actually not only stops the illness in the overwhelming majority, but even in the ones whom it doesn't stop completely, it stops them from getting the severe disease. So we are unbelievably lucky with how effective they are. In terms of how well tolerated it is, it's been better tolerated than most of the vaccines. That's not surprising in a way, because the way in which these vaccines have been produced has been slightly different. So in the past with vaccines, we've got the virus, and we've done something to the virus to sort of kill the vaccine so that the virus can't, kill the virus, so the virus can't actually initiate disease in the person in whom you're injecting it. So there are various ways of doing that. With these vaccines, what we've done is, what the scientists have done, the clever people have done, is they have identified the bit of the genetic material that tells the tells the body to make a little bit of the surface protein that sits on the virus. So when you see pictures of the virus, you've got a ball and you've got sticky out bits. So what the vaccines do is they help the body to make the sticky out bits. So not the whole virus, but just the sticky out bits. And having told the body to make the sticky out bits, the body then recognizes those spike proteins and produces cells that will cells and antibodies that will make those sticky out bits the body react against it should the body subsequently be exposed to them. So because of that, you're not going to get perhaps the full-blown reactions that you might get to some of the other vaccines. So a lot of people with the flu virus historically have said that they after the vaccine they feel like they've actually had the full flu. We're not seeing that with this particular virus. So what we are seeing though, you do want the vaccines to promote a response in the body. So it's not surprising that you do see side effects of it, and it's important to acknowledge that they do exist, because if we try and tell people that you're not going to get side effects, they're going to completely lose credibility, because that isn't the way it works. Most of the side effects that people get, they'll get in the first 48 hours. We do not expect side effects to go on beyond 7 days. And the side effects you get are often mild temperature. Should not be substantial. So if you're getting a substantial temperature, then you should be thinking about other causes and not the vaccine. Aching, headache, tiredness, sore arm is probably the single most common one people get. So as I say, those are the side effects, and they do happen. And interestingly, there's some evidence that younger people get more of those than older people. So hopefully that's helpful. But yeah, we've got 28 million people in the UK have had it, and if we were going to see major side effects, it should be apparent by now.
Thank you. Yeah, just a slight change of plan. We were planning to ask you to put a question in the chat box, but now, as we don't have as many people as we thought, if you do want to raise a question, do raise your virtual hand, and we'll be able to come and see you. So you can put the question in chat or even raise your hand. So please, any more questions, please? Any questions?
Could we maybe pick up some of the questions that have been submitted in advance?
Maybe. Let me just say yes.
Sorry
Sure.
to interrupt. This is Ellie. Just to say that there is a question in the chat from a Kurt Hunt.
Kurt Hunt. Yes. Kurt, would you like to say your question?
Hi, I'm Kurt. It's just a lot of research has been, there's a lot of information suggesting that some people could have the first dose of the Oxford and the second dose of the Pfizer. It's been mentioned, but I'm not too sure whether or not there's been any concrete research to suggest the efficacy of this, or whether or not there's side effects or the benefits of this. So I just want to know whether or not you on the panel have any other ideas about this.
Okay. Shall I go for that? Shall I go for that, or?
Yeah, go for it, Jane, and we'll fill in.
Yeah. And that's a very good question, and it's a very exciting question as well, which has been thought about within scientific circles. It's a concept called as heterologous prime boost, which essentially means that you get one sort of a vaccine, and then you get another one which also goes in, and together, will they give you a better response, or does it improve? And there's all sorts of questions which come with it. There is research at the moment happening around it. There isn't any data that we can sort of put our hands and say that, yes, that will be something that will be advised in the future, but it is being looked at this point of time. And it is happening here within the UK as well, if that answers the question.
Thank you.
And just to fill in Ravi as well, so Sarah Gilbert, who leads the Oxford trial group, was on Andrew Marr about 5 weeks ago. And they are looking at some research where they may follow up the one vaccine with the other one. So there is a trial going on at the moment. There are theoretical reasons why mixing the vaccines might provoke a bigger response, but obviously until that is available, we'll be staying with the same vaccine for the second one, unless somebody's had a particularly worrying reaction to the first. But the evidence doesn't seem to be that you get a bigger reaction with your second dose on the basis of the evidence we've got so far.
Okay, thank you.
We have Leslie who's got a hand up. Leslie, can we unmute Leslie?
Yeah, hello, Ravi. Nice to be here. Actually, no, I don't know what it is about me, but whenever I put my hand up to ask a question, the person before me always asks a question that I want to ask. So I've got my answer. Thank you.
Okay, thank you, Leslie. Okay. Okay, let's just ask
a question in the chat by JK.
JK, can you
yes, it says JK, I don't know if you want to speak about to your question, but it says, if people with a higher rate of mortality more likely to get vaccinated when they are ethnic minorities, less likely if they are at higher risk. I don't know if you want to just elaborate on your question to the GPs.
Yeah, so essentially I was just wondering if there was some data that you guys provided saying that people that are higher risk of mortality are more likely to get the vaccine. But however, if that's the case, then why is it evident that people like ethnic minorities who are at higher risk of mortality are actually less likely to get the vaccine? Why is there a sort of discrepancy between the two?
Sorry, JK, that's my fault because I clearly didn't explain it very well. So the concern we had was that patients who did have a higher risk of mortality were being underrepresented in vaccination. So it was the other way around. It was that that even now there's still an underrepresentation, particularly in that Black African Caribbean population. So that's our worry, really, that we know that people who are more at risk of COVID, of getting complications of COVID, are underrepresented in the vaccine. So there are fewer people from those populations who are coming forward for vaccination. The good news, and the thing I was trying to get across, is that those figures are improving a bit, but they are still not where we would like them to be. So with the Asian population, I think we are getting there, and we're getting there to a certain extent with the Black African and Caribbean population as well, but maybe not quite so quickly.
Thank you. We have a question from Laura. Can we unmute Laura, please? Thank you.
Yeah, hi, good afternoon. My question is, if you've got allergies and you're not even sure exactly what your allergies are, you just eat particular foods and then sometimes you just have a reaction to it. Wasn't they saying on the news that they were advising those people not to take the vaccine?
Dr. Jane?
In terms of allergies, what the guidance around that is that if you're known to have an anaphylaxis, which is a heightened reaction whereby in the past you've had to perhaps be given medication for it or given adrenaline in the form of a pen, and that's been diagnosed, those are the cases where we normally suggest that, yes, you need to inform your GP about it, but that's more specific to the actual actual components of the vaccine. Or if you have a reaction very similar to it and it is completely unidentified and you have multiple sort of numerous foods where you are having sort of this very similar reaction, in which case you inform your GP. And then the GP will go through your history very carefully and then make a decision as to what is the best way forward. So it is not a case of no as such, but it is in those cases we very much scrutinize and come with what would be the best solution forward. So there's only a very, very, very small cohort of people, and these are people who, let's say, for instance, you've been unfortunate to have your first vaccine and you end up having a full-blown anaphylaxis, or you are known to have to a particular component of the vaccine where you've had a previous anaphylaxis, whereby they say that you can't have it. But even in those cases, there is a sort of we have teams and specialist teams where we look at it, whereby perhaps you might not be able to have one vaccine, but you might be able to have the other one. So there are ways around it. So if you're never sure of it, what we would always advocate is please speak to your healthcare professional, which is your GP, who will keep it, and we can look at that for you. So there isn't anything saying you can't have the vaccine categorically. It's a discussion, and the likelihood is that that we'll find a solution to look at it or get over it in most cases. I'm not sure, Patrick or Shanaz, if you want to add something more to it.
There was a thought that obviously the AstraZeneca tended to be less likely to cause allergy. So particularly for people who had some concerns about anaphylaxis to an unknown agent. And also the other thing is that we can confer with immunologists. So locally we can confer with them and get their advice on that, and potentially think about having vaccination in a supervised environment.
Thank you, Mariam. Laura, I hope that's helped. What I'm going to do, I'm going to submit a question that it's been already in advance. And the question is, do the vaccines contain a live virus? Mariam.
So the vaccines that we have available are the Pfizer and the Oxford AstraZeneca. So that the Pfizer is an interesting new innovation where they put the mRNA in a kind of lipid envelope, which is then taken up by the body. And then once in the body, it sort of promotes it or stimulates it to create a spike protein, but the mRNA is then broken down, so it won't continue to reproduce. And similar to that, the Oxford AstraZeneca is made up of a weakened adenovirus, which has been specifically changed so that it can't replicate when in the body. So it's a vehicle to then basically get into the body and stimulate production of a spike protein. So you can't get infected with COVID-19 by having the vaccination.
Okay, thank you. I think it's down an old hand. Laura, do you have another question?
No, I've got another question.
Oh, okay.
Have there been any recorded deaths of people after having this vaccine?
Patrick?
Yeah, do you mean it directly attributed to the vaccine? So
Sorry, I mean that people that were perfectly healthy and fine prior, so there's no underlying health conditions, they've had the vaccine and then, you know, shortly afterwards have passed away. Has any of that been recorded?
Yeah, so I mean, the answer is no. The good news is no. There are obviously 28 million people who've been vaccinated now. So when you have a population like that, you're going to have events that are happening just in the normal population. So what you're always asking that situation is not has it ever happened, but has it happened any more than you would expect? So we cross the road, and we cross the road the day before our vaccine, and we cross the road the day after the vaccine. The fact that we might have a meet up with a car in the middle of the road on the day after a vaccine is exactly the same risk as it would have done before. So the answer to your question, Laura, is no. But you will see in reports, in the news and so on, things like that we've had in the last couple of weeks about is there possibly an association with thrombosis. So when you see those reports in the news, just be a bit suspicious about them. You know, bear in mind there's 28 million people who've had it. There is a robust system for reporting on adverse reactions to vaccines, and we all send in reports if patients tell us that they've had a significant reaction. So that data is all being collected nationally, and so we can be confident that that there aren't any concerns of that nature, and anything that does come out, you know, will be reported. You will be hearing about it.
Thank you, Patrick. I think we've got Kurt Hunt also wanted to ask another question. Kurt?
Yeah, thanks, guys. Just want to get an idea from the panel. What's the thinking behind the booster jab that they're suggesting in the autumn? Because it sounds to me that it's quite soon, really. People still having their second jab, and they're talking about probably the need to have a booster jab in the autumn before the winter. So, and especially with the new variants also, I want to know what's the thinking behind all of that and how it's going to work.
Dr. Jain, can you answer that?
Yeah, thank you, Ravi. I think this is perhaps, yes, it's the way you look at this data, or information rather. It's actually a celebration of science that we are at a day and age where you have the capability to actually tweak vaccines so quickly to bring about efficacious medicines out there. But equally, the question about have they decided about it? Are we hearing rumors? We all hear what you're hearing, but I don't think there is anything tangible to say that, yes, we have identified a few variants where we need to tweak the vaccine and bring it out. This might happen because evidence has sort of everywhere within the scientific community. It is a known fact that COVID is going to probably hang around for if not 5 years or so, but in what shape and form we do not know. Now, all viruses, just like the flu virus, every year they have the potential to sort of start changing, and there can be variants which come about. At this point of time, there isn't anything that says that we have identified a variant where we really need a new vaccine or tweak the vaccine that we have to actually deliver something different. But the capabilities exist just because of the novel technologies that we have, which Shanaz has mentioned previously about the mRNA and the adenovirus. Now, just on that front, just to bring it, that there's always this notion that mRNA is some sort of a very new, novel sort of technology. The first mRNAs actually were sort of talked about in the early 1990s when the actual jabs, which were mRNA based, were done. But because we didn't have the other capabilities around it as we have at the moment, where we could form this sort of a lipid film to get it into the body safely and make it efficacious, that technology didn't sort of arrive up till now, which was just accelerated. And going forward, most of the cancer treatments in the next 2 to 3 years are going to be in this form as well. So what we're seeing here is that sort of very good scientific and very clever people who have been able to develop all of this and give us that ability to do it. So going back to your question, have we decided, will it happen? Not that we are aware that that's the way we are planning at this point of time, but in the background, something's happening. There is that institutes are tweaking, if need be, slightly things around, which is not necessarily meaning that it's a whole change of it, but that's part of how vaccinations anyway happen. It's part of their process where slight tweaks happen all the time, but nothing that's major.
Thank you.
Thank you. We've got another question from Leslie. Leslie?
Can I, sorry, Ravi, just to follow through on that, just on the same topic.
Sorry.
Don't worry, that's no problem. So the reason we think we might need to do a booster program is because it's the same family of viruses as the flu virus. So we know that the adaptation means you have to adapt it year on year. And one of the we covered earlier on that thing about maybe mixing vaccines, and one of the interesting features is that mixing vaccines may help to address that issue about dealing with variants. The really good news with variants is that historically variants typically happen very slowly, and an individual vaccine doesn't lose its efficacy completely with these little changes. So although you see a lot of stuff about the new variants in the press, actually they probably don't matter a huge amount at this stage. And viruses do two things. There's a thing called antigenic drift and antigenic shift. So basically they've got little changes, and that happens on a regular basis, and then there are big changes, and the big changes are much less common, and that's where having to really adapt your vaccine, that's where that really comes in, where Jayan was talking, that you have to actually remodel the vaccine. But as Jayan says, we're in that really happy situation where the technology exists to enable us to do that really quickly now, because they've got the capacity to detect the DNA really quickly, and therefore make your changes to vaccines on the basis of the DNA. So we are lucky to have a coincidence of this dreadful virus at a time where the technology is in a position to match it.
Thanks.
Thank you. Leslie? Can we unmute Leslie?
Yes, hello. Curious to know, if you happen to have coronavirus, how long after you've recovered from it, and presumably then would test negative, would you wait until you had a vaccination? And how would that work?
Dr. Mariam?
So I was in the situation of actually having had COVID, and then I was vaccinated. So the current guidance is that you can have the vaccine 4 weeks after you've had the infection. So as long as you've primarily recovered from the infection. And the idea is that we're not really sure how long your protection lasts when you've got natural immunity, when you've basically had it because of getting the infection. So that's the whole emphasis on, it would be much better to make sure that you also have the vaccination. So we shouldn't assume that just because you've had the infection that will cover you. We would definitely say that having taken the requisite sort of at least 4 weeks to after having had the infection, you should go ahead and have the vaccination.
Thank you.
Thank you.
So what would, sorry, just to finish this off. So if you had somebody who was in that situation, would you then, because obviously due to the fact that they've got the infection, they may miss their slots, so to speak, would you then recommend them to contact their GP surgery and explain the situation?
Absolutely. So we often keep a list, and we have vaccine coordinators, and the idea is that if they've been contacted or they can get in touch with their GP surgery and let them know that because they've had the infection that they can't take it now, then they will then contact them again, and they should know that it will be sort of as long as that 4 weeks has passed, they should be able to have it.
Thank you.
Thank you. We have a question now from JK.
Hi, yeah. So essentially, in response to what you just said, you were talking about there isn't a proper idea of how much protection, how long the protection lasts for natural COVID immunity. Do you have is there a ballpark figure for how long the vaccine's supposed to protect you?
If I come in there, Ravi. So when we started the vaccine, when we started the vaccination program, there wasn't any evidence about duration of protection from natural infection, but there has been a paper that's come out since vaccination started, which suggests that you got protection for up to 8 months. Obviously, the advantage of vaccination is that it's going to do. That's the reason you have two, is so they have a booster. So if you think about it logically, that vaccinating somebody who's had the illness effectively means that they're getting a booster. And we know that with flu, we know that by giving a booster every year to those people who have been at risk of it, that gives them that sort of cumulative protection, really. So so that would be the rationale, JK. You're trying to continue to encourage the body to recognize features of the virus, whether it be from having been exposed to the full virus or from triggering the body to make those spike proteins that exist on the surface. So that's the rationale behind it.
Thank you, Dr. Patrick. I've got a question now from Nina. Nina, would you like to ask your question?
Hi, I was just wondering, really, all the scares have been around the thrombosis being from the AstraZeneca and not Pfizer. Is it a ploy from Pfizer, or is there any basis behind it?
Dr. Jane.
Thank you. Yeah, Nina, that's a very interesting question, but I don't think that there's any flaws as such. I think it's got to do with vaccine sort of rollout. And I think what was seen was this spike, which was seen in some of the European countries, where they picked up that there was a fairly very high spike in a population that you wouldn't expect of having these sort of thrombotic events that were happening. And it is right that every country would do that, is that you start scrutinizing a lot more of what has been seen. Now, what is reassuring, as Patrick has reported before, is that both the European regulators and the US regulators have looked at the data, and there has not been anything that suggests that there is an overall increase in clotting conditions like DVT or pulmonary embolism by administration of the COVID-19 jabs, particularly the AstraZeneca one. Now, there were some very rare sort of thrombotic events which were seen. That is why it was more to do, paradoxically, the other way around, where it was actually the count of your platelets, which make blood stick, were less, and as a result, people started to get clots, which they are monitoring at the moment, but there isn't anything sort of suggesting a cause and effect kind that you've had the vaccine, that's why this has happened. Yeah. And we know for a fact that COVID infections do it the other way around, where you actually end up having clots. So this does not sort of, even with the actual protein you're putting in, sit with what we would expect. So it's a completely different sort of way of how it's manifested. And hence why looking and very much scrutinizing the data, nothing has shown that, yes, this has only been seen for AstraZeneca and it's Pfizer the way around or anything of that sort. It's just what I think is due diligence, which countries have looked at. And obviously the way they respond to it is dependent on how their systems are in place, which we can't comment about. But I think the good news out of all of this is that it has reiterated again that the vaccines are safe, given the data we have from 27 million from here, and globally with all the vaccines that have happened, that there hasn't been anything to suggest that we need to be concerned.
Thank you. Anything else to add from the Dr. Patrick?
Yeah, I was going to say, so just Jane sort of used a nice little analogy there. So if you've got 1,000 people who are going to be vaccinated, and you know that there's a risk of thrombosis just because there's a risk of thrombosis, you might expect within that 1,000 people, one person to have a thrombosis just because that's what happens in the general population. If that happens to be the 8th person you've vaccinated, as opposed to the 992nd person, you're going to be thinking this is a bit scary. You know, you've only done 7 and one of them's happened. But we're in the situation now where people have looked back at the 27 million in the UK, all the data from the States, and now the data from Europe, and we know that it's no more likely to happen. The comparison is, you know, that I was making before was crossing the road. You know, you're no more likely to be hit crossing the road on the day before your vaccine than the day after, and you're no more likely to have a thrombosis the day before your vaccine as you would do afterwards. And Jane's point is really, really important about the disease itself. So we started off thinking about COVID as a respiratory illness. If you hear the specialists talking about it now, they don't talk about it being a respiratory illness now. They talk about it being a vascular illness. So this is an illness that will attack your blood vessels and your clotting. So the disease itself definitely causes thrombosis, and the vaccination does not, as far as the data shows at the moment.
Thank you, Patrick. We've got 3 questions coming up. We've got one from Jana, one from Ali, one from Tanya from the Alzheimer's side. So we'll start with Jana, then Ali, and then Tanya. So Jana, and then we've got JK afterwards. Jana, would you like to ask a question?
Good afternoon. I would like to know, I had COVID infection around Christmas time and I'm still recovering. I had my first dose of AstraZeneca middle of February and was really unwell for about a week. Should I have my second dose, and is it likely to cause me further problems? So I had a week of quite unpleasant side effects from the first dose. After the second dose, am I likely to have similar side effects?
Mariam.
So first of all, sorry that you have had both the very slow recovery from COVID and but also the side effects from having the vaccine. Though obviously we accept that they are very common, as elaborated on by Patrick before. You know, very commonly you will get the kind of aches and pains and headache, and it can feel quite unpleasant. I guess that is a sign that your body is mounting a response, and in some ways that's a good thing. I think it's difficult for us to definitely say that it would happen the second time, but that doesn't always happen for other people. Some people find that it's particularly with their first dose that they have a response or kind of side effects, and the second dose doesn't necessarily follow the same route. But again, I would still say it is important for you to have that second dose, just to make sure that you are covered to the extent that we would like people to be covered by 2 doses of the vaccine. Patrick, I'm not sure if you had anything to add on that as well.
Yeah, there is a little bit of evidence that your second dose you get less of a reaction, which is the good news for you, Ellie. But the problem with all this stuff is that, you know, 1,000 people, you're going to have variation within that. So we can't promise that you're going to have less reaction. What I would do in your situation though is I would almost in anticipation take a couple of paracetamol, you know, as soon as you come back from the clinic, really. But the good news is, you know, you are now sitting in a situation once you've had that where you've got really, really really good protection. Yeah, you've got the illness and the protection that's come from that, and you'll have had your 2 vaccines, so good on you. You know, you are well protected yourself, and you are not at risk to the community, so you've done your bit for the community as well as for yourself, so good on you.
Thank you. We've now got a question from Ali. Ali, would you like to ask a question?
Hi, afternoon everyone. I was just wondering what the current guidance or research is with regards to young women who are conception age, with regards to taking the vaccine prior to pregnancy, because have there been any findings in this 27 million that you keep quoting? I'm very sceptical, by the way. I'll just warn you now. You know, to indicate that it is safe or isn't safe, because obviously, as ancient as I am, I call to mind parents' fear of MMR with their autism, or the 80s sort of situation with the thalidomide sort of era. So I was just wondering, what have you got with regards to that, and if that's the case, sort of where is it you're getting this information from that we're supposedly trusting this afternoon? Thank you.
Mariam.
So I think this is a really important issue to talk about, because I know that has been a concern, from a number of groups in terms of concerns on both fertility, but also for women of the conception age and also who might be pregnant. So it's really quite interesting, because actually in some of the trials that were done in the US, they actually had 23 women who were pregnant and received the vaccine, and there were no fetal losses because of the vaccine. They've also vaccinated pregnant women in Israel, and they were sort of in their 3rd trimester. And again, there was no harm to the mother or the baby. And actually it conferred some protection to the baby. And some of that may be from breastfeeding, and some of that may be through passive immunity, where the protection is passed through the placenta. So we've definitely got some evidence. And I guess that's the thing. A lot of these trials initially, they don't have pregnant women. But we are definitely getting more research being done on pregnant women. And currently the advice is that if you have an underlying health condition which puts you at particular risk, or you're in a situation as a healthcare worker or someone that is likely to be in contact with COVID, we would say that actually getting the vaccine, you should still consider getting the vaccine after discussion with your doctor. And it may be that at some point it will be more routinely offered to people that are pregnant. In terms of fertility, I just wanted to say, I don't think there's any evidence that this particular vaccine will cause long-term damage to someone's fertility. So as I say, both the mRNA vaccines as well as the Oxford AstraZeneca, they are broken down by the body, so they don't remain in the body, and it shouldn't then have a long-term effect on fertility.
Thank you. We've got now a question from Tanya, then we'll take one from JK and then Laura. Tanya?
Thank you.
Thanks very much. Yes, I've got more of a sort of procedural question, really. I'm from Alzheimer's Society. Oh, can you hear me? Yes. So I manage a team of frontline workers at Alzheimer's Society. And, you know, we're delighted everyone's been offered the vaccine and so far taken it up. There's a bit of confusion around second vaccinations, though, because some of us went through the CCG pathway, others went through the council pathway, because my funding streams are different. And what should be the gap between the first and the second dose? Because we're struggling to get our second doses booked. Maybe we're too soon. I don't know. Thank you.
Patrick.
Thank you. Yeah, it's probably too soon, Tanya. So the practices are given notification of the vaccine coming, so that it's given between day 77 and day 84. So the earliest the practices are going to hear about their delivery is on day 70. So everybody who's had the vaccination at a particular point, we are told that there is a guaranteed supply that is going to arrive of that particular vaccine for that time. So if you get past past day 77, start hassling people. If you're before day 77, then that's okay. If it happens that somebody gets their vaccination at 12 weeks plus 1, plus 2, plus 3, it really doesn't matter. As long as it's done sometime around that, it's okay. But basically, if you get to day 77 and you haven't been nudged, then you should be nudged.
Thank you.
Is that okay, Tanya? Because can I just go back to the last one if that's answered that?
Sure,
so Tanya,
sure. Yeah, go ahead.
Thanks, Ravi. It was just on that previous one because Ali made a really, really nice point about the history of medicine. So thalidomide was just a total disaster. That was, pharmaceutical industry nadir really in terms of drugs being pushed out onto the market without adequate research. Significantly, of course, with the COVID vaccine, we were very cautious and identified that it should not be given to pregnant women, because there hadn't been any trial data done on pregnant women. Shanaz has very accurately pointed out that we now do have some data. It's only small data, but the current position with pregnancy is that women are not advised to have it unless there is an overwhelming risk of COVID for those individuals. So by and large, women aren't going to be offered it. Clearly, there will be a number of women who have had vaccination and then become pregnant without intending to. We have not come across any consequences as a result of that. The other comparison you made was between thalidomide and MMR, and that's a really good one. Thalidomide was just terrible. From a point of view of sort of scientist and a doctor and being associated with those things, it was just awful as a sort of piece of planning, getting a drug onto the market, and there were an awful lot of lessons learned from it. MMR, you can't make that same comparison to MMR. So the problem with MMR was that an individual person wanted to promote a particular agenda that they had, and it had a massive impact on the population because the fear that's existed since thalidomide has been sort of perpetuated through. So there is no data that links MMR to autism, and this is something that has been looked over. The data on this is extraordinary now, and because there's been so much attention to it, we know definitively that there is no association between those two things. But the memory of it carries on, and the memory of thalidomide will be with us for generations to come as a lesson in what we should not be doing. But it does make the point that we've got to be cautious about sources of information that have a particular agenda. And to be suspicious of them, and that's why events like these are so important, because people can have the opportunity to ask that question, and hopefully in people from their community who they are likely to trust, and not representatives from drug companies or from CCGs. I have a role within the CCG. Shanaz and Jay do not have the same leadership bit that I have, so they are freer to speak. So you will get dispassionate views from the likes of Jay and Mariam, and hopefully me as well. So I thought that was just a point worth making.
Hopefully, Ali, that's answered all your questions. We haven't got much time left. Did you want to say something, Dr. Jay?
Yes, just following on to what Patrick has said, I've just put in the chat, Ali, something to look at, which is the position statement of the Royal College of Obstetricians and Gynecologists and Midwifery around fertility, which is their official statement, just for you to have a look, which shows that there is no evidence suggesting that COVID has any impact on fertility. So I just thought that would be worth, if there are people who contact you or you'd like to know, and would be useful to share. Thank you.
Is that okay, Ali?
That is. I did have a quick question if there was space at the end, but I really do appreciate that, Dr. Jacob. Thank you, and Dr. Muin and Dr. Gibson for your responses. I do recall the fear that was around the MMR, and so I was wondering if it is rolled out to children, is there something that we should be thinking about? But obviously that's been cleared up. But if there's space at the end, I did have one other question that was sort of niggling. I'll wait my turn.
Can we go to JK first, because I know he's been waiting.
So I was wondering, are there any particular programs or initiatives out there being undertaken in the local community to target particular ethnic minority communities to increase vaccine uptake? Is there anything going on to particularly target the Black African community, the Asian community, to sort of, what is being done to narrow this?
Yeah, thanks, JK. Yes, there's a lot of work going on in that. So Jayan's wife actually presented at a meeting with the London mosques. Myself and the other borough leads are getting out to speak to any community groups that we know about. And if any of you know of community and faith leaders, so any of those community groups that you can put me in touch with, I would really appreciate in Richmond. That every meeting I go to, I ask to be put in touch with those sorts of groups, so that I can get out to talk to them. So yeah, there's a huge amount of work going on in that.
Thank you. Okay, Laura.
Okay, I'm going to try and be quick. Dr. Patrick kind of answered the first questions. I was going to go back over the vaccination in regards to fertility, and I wanted to know, why is it that we're being given this confidence in this vaccine that is relatively a new vaccine, to be told yes, it doesn't affect fertility? How do we know that? I mean, sometimes you don't see these side effects until years later. So where is this confidence coming from that it's safe with fertility, it's safe in pregnancy? I mean, I've read literature where it said pregnant women should not be taking the vaccine, but I'm hearing on this platform that no, it's okay to take it. So I'm a little bit confused, and I don't know where this information is coming from, you know, to back up what's being told to us today, that it's safe to take it in pregnancy, it's safe. How would we know if it's going to affect fertility until years to come?
Mariam.
So I should have made it clear. Again, as Patrick said, there are some circumstances where we would say the benefit from vaccination, even in pregnant women, outweighs the risk to them. And it really depends on the risks. So if you're a healthcare worker and you are pregnant, or if you have really serious underlying health conditions and the risk to you posed by COVID is considerable, then in those circumstances, you can discuss with your doctor and make a joint decision, because obviously it's your decision as well. We want people to be informed and make a decision along with their healthcare professional. We definitely have some evidence that people have gone through pregnancy and been vaccinated, and there hasn't been any harm to themselves or the baby. But we understand that obviously in the study populations, we don't usually have pregnant women. So that's why this is an area that we just need to continue to monitor. But I think it really does depend on risk-benefit ratios. In terms of fertility, I mean, we know that we give the flu vaccine to pregnant women. And again, that's to protect them. And very similar to the flu vaccine, again, we're giving patients something to stimulate their own production of sort of a protein, which would then enable them to mount an immune response against the real virus, whether that's flu or in this case COVID. And that the actual thing that we're giving them, the vaccine, is actually broken down by the body and got rid of. So it doesn't linger. It won't then kind of pose a kind of a risk to the body or affect fertility from that point of view. And I think that's what we wanted people to understand, because obviously that would mean that if you are telling people that there is a potential risk, then they will be afraid of that and then will not go on to be vaccinated. And that's putting both themselves and their families at risk. And there's there's no evidence that there's any risk for people's fertility, whether that's male or female, particularly if we know that those components that go into the vaccine are broken down and they don't linger on, and they're certainly not affecting the kind of the DNA or nucleus of anyone's cells.
Just for clarity as well, so at the moment, the current position is that we are not recommending that pregnant women are vaccinated. So until we've got lots of evidence, we won't be recommending that. What we were maybe slightly clumsily trying to say is that there is evidence growing that that there are some women who've been given vaccination or have become pregnant and then become pregnant and then been vaccinated accidentally, and we know that so far there has not been problems with them. But you are absolutely right that it's going to take time before you have women who've gone through the whole of the pregnancy. So the vaccination trials started in about September, October. So if you think about that logically, that even the people who were vaccinated, who were pregnant right from the very start, who might have been vaccinated, they won't have gone through the whole of the pregnancy. So, and until we've got that data, we will not be recommending it as a routine to pregnant women. What we're trying to say is that where accidentally there's been a coincidence of pregnancy in the vaccine, there have not been adverse outcomes, and the nature of the vaccine is such that we would not anticipate that. But you cannot say that, and then you can't say that you wouldn't anticipate a problem, then it'll be okay. What you've got to do is to show definitely it's okay, and then you actually proceed with vaccinating pregnant women.
Thank you very much. I think we've almost come to the end of time, but I've actually got a question myself just to wrap up, and that is the mistruths and the stories which are going around social media. What would you advise people when they see something and you know it's not true, but people are talking about it? What would you advise? What's the advice to those people who are looking at these stories and mistruths?
Work out who's the person you trust most and have that conversation with them. If you haven't got somebody like that, you know, one of my roles is to offer that. So speak to me or speak to other people in your local community who you do trust. You know, it's great having social media. It adds a huge amount of color to life, but what you want is quality information, and you would choose to get that from the person you trust most. So don't trust what you see from an anonymous person whose track record you have no idea about. Yeah, so the one thing I know that one of the questions that came up in advance, Ravi, was about young people as well, so vaccination for them. There are trials on people, young people between the age of 12 and 18 going on with AstraZeneca at the moment, so we're hoping that we'll have evidence about vaccination for children down to the age of 12 fairly soon.
Okay, thank you. Anything to add, Mariam, Jane?
So there are lots of really useful sources for advice as well. So the British Islamic Medical Association has got some information, and given that we're also going into Ramadan very soon, we just want people to understand that actually that the current advice is that they can definitely get the vaccine even during the fasting period.
Okay, thank you. Dr. Jane, anything you want to add?
I think I just want to reiterate what Patrick and Miriam has mentioned as well. It is one that if you've got questions in terms of, feel free, and your GPs would be fine. For instance, I'm very happy. I always have conversations and I ring people who sort of have had vaccine hesitancy to sort of understand myself, because you see, it is very right when something has come out so soon to feel worried about is it right, what's there. But there is also a lot of very good information, as well as information which is very difficult to trust. And sometimes it is very hard to weave through all of it. So if you're not quite sure, look, just send an email or just let us know, and we're more than happy to look through that and share what we know. We don't profess to say that we have the answers to everything, but for most of the stuff, we'd probably be able to guide you so that you can make an informed choice.
Thank you. Just finally wrap, any final thoughts you want to give to the people who have come to this session? Final thoughts, reflections that you have? Mariam?
Yep, sorry. Well, just that it's good to kind of try and have conversations about your concerns. If you have concerns, then, you know, it's great to kind of talk about that. don't always follow the kind of WhatsApp messages from goodness knows where and then share them as well. Better to have, you know, an honest discussion and talk about what you're concerned about, because actually sometimes things that you're concerned about can be explained and you know, you might be reassured, but at least you're starting that conversation with the right people.
Any final messages, Jane, Patrick? Patrick?
Thank you. Yeah, yeah, if you believe in public service, the three people on this panel believe in public service, we are here to help you. So if there are queries you have that we can help you with, and the things we can reassure you with, you know, and you can't get answers from elsewhere, you know, that's what we're here for. So the message really about vaccines is this is a really nasty illness. We are unbelievably lucky with the vaccines we've got, that they are much more effective than most of the other vaccines we've ever had, because of this ability to identify their genetic makeup early, and the technology that allows us to make the vaccine quickly, and also that they are genuinely really well tolerated. They do make you feel a bit rubbish for a couple of days, for a lot of people. Some people feel absolutely fine with it, but lots of people do. But don't let that be a reason to stop you getting this vaccine. This is a really unpleasant illness, and we have the capacity to stop it in its tracks. We're seeing the evidence that is there already. Yeah, you know, 6 weeks ago, 8 weeks ago, Kingston Hospital's intensive care unit was absolutely chocker. Today, there's only one patient with COVID on intensive care. I think there's only 14 patients in the hospital who've got COVID now. So we have, with the combination of the lockdown and vaccination, we've completely sat on this illness, and but we do need to keep going with it, because you know, you let up and the virus will come back and bite us on the bum.
Thank you. Jane, would you like to say a few words?
Yeah, I just want to say that thank you, Ravi and the team, for organizing this. But also, I think the most important thing about this is that we have given you the information, we have tried to answer your questions. But I think that who can make the greatest difference is each one of you, because it's you who will be able to sort of convince, and your talk with those who probably are not sure about, or sharing this information is what's going to make the biggest difference, rather than us here sitting. And I know that from personal experience, because I've had sort of people who I've shared the information, but there are people who have taken that on board and actually gone and told my patients, who've actually been able to sort of grow confident and actually also get people to come and talk to me as well. So I think that's the biggest sort of request from my part, is that what you've heard today, if there's anything more, please follow up. But y'all are the ones who can make the biggest difference. So thank you for that.
Thank you, everyone. Now, just before you all go away, there's going to be a quick poll. So can we have the poll, please?
It doesn't work. Oh, I knew it wasn't going to happen. It's not working. I'm sorry. But yeah, I can't make it. I don't think I can make it work. I'm so sorry. I've just been trying furiously.
Okay, not to worry. But anyway, I'd like to thank all our doctors, all our experts. I'd like to thank Richmond Council and South West London CCG Group, and all of you for attending. It's been absolutely, it's really been so important that you came and answered all your questions. And I hope you are now better informed. And please, if you do have any questions, please go and ask your doctor anything that you have. Any queries, any concerns, any fears, do ask the experts and the professionals. Do not rely on anyone else. So thank you very much.